some communities experience decrease at a much higher rate than others. This is a common thing that we hear. If you teach teens about contraception and safe sex, it's giving them license to go out and do it. So, you know, if I teach my kid all these things, aren't I telling them, you know, this is fine with me. Go ahead, go out, have sex. In fact, we know that that is not always the case. And in fact, survey data supports that if you teach your teens about contraception and safe sex while teaching them your family values, whatever those may be, as long as they're not harmful, kids are more likely to make better decisions around sex and relationships, and they're more likely to wait longer to initiate sex and be safe when they do. Teens want to talk to trusted adults, parents, and healthcare providers about sex and relationships. And, you know, if you listen to the media, you might see, you know, get a sense that teens just want to talk to teens. They want to use the media. That's where they want to get their information. But we know that the National Campaign to Prevent Teen and Unplanned Pregnancy does a regular national survey that generally supports the idea that teens want to talk to trusted adults, especially parents. Now, whether they're getting information, correct information from them, or not, we don't know that, but we know that if they could choose to talk to someone that they trust, they would want to talk to their parents. And then another thing we hear is Indiana is an abstinence-only state. So when people say that, I think they often mean like we as educators, as community-based providers, as nonprofits, as schools, like there is this thing, this law or this policy or something that exists at a state entity that supports that and only abstinence may be taught in our schools and community centers. And that may be a local decision in your agency or school, but there's not a, and we'll talk more about this, but there's not a law that says this specifically. So we want to look a little bit at what unintended pregnancy in the U.S. Looks like. So if we look at this, you can see on this graph, about 51% of pregnancies are intended and about 49% are unintended. So what does that mean? It means that nearly half of pregnancies are unintended. And that has a lot of potential impacts. When you look at the pregnancies, we're going to use 2006 data for this. When you're looking at unintended pregnancies in the U.S., about 4 million resulted in live births, about 1.4 million ended in abortions, and about 1 million ended in fetal losses. And then if you look at the unintended pregnancies, the 49%, about 1.6 million resulted in live births, 1.4 million ended in abortion, and 0.2 million ended in fetal losses. So then you look at intended pregnancies. Within that, you have about 2.6 million resulting in live births and 0.9 million resulting in miscarriages. So you can see that there's a lot of different outcomes for pregnancy, whether they're intended versus unintended. And this is very interesting. So if you think among women aged 19 years and younger, more than 4 out of 5 pregnancies are unintended. So it's just, and then you contrast that with among unmarried women aged 20 to 29, nearly 70% of pregnancies are unplanned. So we know that there is a lot of things that go along with pregnancies being unplanned, whether that's access to prenatal care, and whether and then we need to look at strategies that help us diminish this unintended pregnancy rate and the resulting. We look at unintended pregnancy, there's another frame to look at the cost of unintended pregnancy because we know that this is significant. So there was a literature review in 2007 that looked at the total economic health care burden of unintended pregnancy. So what does unintended pregnancy look like in terms of dollars and health care? So in this literature review, we look at direct medical costs of unintended pregnancies, around $5 billion. And then if you looked at what could potentially be a direct cost savings, medical cost savings due to contraceptive use, that was estimated around $19 billion. So there's significant financial issues around unintended pregnancy. So let's look a little bit at what the data says around teen pregnancy specifically and teen births in Indiana. So in 2014, you can see the pregnancy rate was about 32 per 1,000 teen girls aged 15-19. That's the pregnancy rate, and the birth rate was about 28 per 1,000 teen girls, 15 to 19-year-olds. And then you can see that if you like the number format, there's 6,218 teen births in Indiana among girls 15 to 19 in 2014. These ranks shift a little, but you can see we're about 24 for teen pregnancy rate and about 35 for teen birth rate. I love this slide because you don't think about it in this context always, but when you look at teen pregnancy rates worldwide, I mean, just look at the U.S. If you look at that graph for a minute, you know, what does that mean? It means that there are some significant differences in how we're approaching teen pregnancy and teen birth in the U.S. We have some data that supports that U.S. teens are less likely to use contraception and that they have less access to reproductive health services and sex education than the rest of the industrial world, because the rates are not different. When you look at sexual activity among teens, European teens have similar rates of sexual activity. And so this lack of access to contraception, lack of access to reproductive health care, there's some data that supports that there's more of culture in some European countries of, you know, we expect, because we know that most people have sex by the time they're 19, we know that to be a truth for most people, and so we expect that you're going to be sexually active, and we also expect that you not have a pregnancy outside the context of a committed relationship. So that's not as measurable, but you hear that often in this discussion. Okay. And then we want to look at the public costs of teen childbearing. So we talked about the cost, medical costs potentially of unintended pregnancy for teens and young adults specifically, but now we're looking at the public costs of teen childbearing. So this is not to say that you cannot have an unintended pregnancy as a teen and not be a successful person and have a strong family and love your child, but this is to say that there are some significant costs associated with teen childbearing. And the National Campaign to Prevent Teen and Unplanned Pregnancy does a good analysis of this data, looking at 2010, estimating some of these costs to Indiana taxpayers associated with teen childbearing to be around $227 million. And some of those costs that they're talking about, so you're thinking, what are the costs? What are these costs of teen pregnancy? Which is a good question. These costs are estimated looking at costs associated with public health care, so Medicaid and CHIP. There's an increased risk participation in child welfare for children of teen parents, and for children who have reached adolescence. There's an increased risk of incarceration and all of the associated lost tax revenue for having people that aren't working, young adults and teens. So that's kind of the cost they look at to estimate these costs associated outside of just Medicaid. So you see, if there's a majority of pregnancies are unplanned for women 15 to 24, and if around 69% of males, 68% of females have had sexual intercourse by age 19, we kind of know that education and highly effective contraception are a really critical piece of the puzzle. Thumbs up. So a brief overview of what Indiana law says about sex education. So we say we need education. We say we need access to contraception. And by education, we don't just mean like, let's go teach all the kids how to use a condom, but what does a healthy relationship look like? High quality, comprehensive, inclusive sex education. So when we think about that, the Indiana state law that applies to the Department of Education, it requires a teacher to teach abstinence from sexual activity outside of marriage as the expected standard for all school-age children. And let me preface this by saying, if an entity decides to teach sex ed, so if a school decides to teach sex ed, which is where we know is one of the most effective ways to reach the most kids, if they do, they're not required to, then these are the things that go along with it. They also, outside of requiring a teacher, they also must include in instruction the abstinence from sexual activity is the only certain way to avoid out of wedlock, and this is the language in the legislation that I'm reading, only certain way to avoid out of wedlock pregnancy, sexually transmitted diseases, and other associated health problems. And they must include in the instruction that the best way to avoid sexually transmitted diseases and other associated health problems is to establish a mutually faithful monogamous relationship in the context of marriage. So that is the language in the current legislation that's applied to school-based education. What it doesn't say, though, is that you may not teach other things. So if you teach it, you must teach these things, but that does not prohibit teaching other things that help, including things like, what does consent mean? What does a healthy relationship look like for teens and young adults? What are your contraceptive choices to avoid pregnancy if you are sexually active? How do you negotiate in a relationship? What are STDs? How do they present? How do you know if you have one? How do you avoid them? So it doesn't say you may not teach those. So that comes down often to local control. What does your school board say? What does your school say? But the law is supportive of teaching other things outside of just these required items. Oh, there you go. So what does that mean? It means if you teach, like we said, you must teach the previous topics. Doesn't mean you can't teach the others. HIV education is the one thing that is required by law. This looks very different depending on if you're talking about school-based education, it looks very different. It's required, whether it's inclusive, medically accurate, that is just school by school, district by district. There's no real clear parameters on how that must look like, just that it's required. And like we said, local control determines that. So before we move on to Mary's piece, when you're speaking from an education perspective, what works from an education perspective, if this is one piece of the puzzle with contraception and LARC? Evidence-based teen pregnancy prevention programs. So there are programs, they're not all designed for schools. There are programs designed for schools. There are programs designed for community-based organizations. There are programs designed for clinics. There are protocols designed for healthcare providers. So evidence-based in this context, meaning, like it often does, that an evaluation, a rigorous evaluation, has shown that there is behavior change in the target population that this program or protocol addresses. Programs should be age appropriate and medically accurate. Medically accurate according to a medical healthcare provider. Programs that fit target youth and communities. So not taking a program that was developed for medical providers in rural Wisconsin applying it to medical providers in urban Philadelphia. This is just an example. So making sure that if you're picking an off-the-shelf on the Health and Human Services of evidence-based programs or others, that you're fitting to communities or making appropriate adaptations if you need to. Making sure that all programs are inclusive of LGBTQ youth, not just by saying this program is inclusive, but by looking at it, putting it through review, having people look at it. How am I making sure I'm including all youth that may attend this program? Very important, skilled facilitators, skilled healthcare providers, people that are skilled in working or providing healthcare to teens and adolescents. And then incorporating aspects of positive youth development. So into any programs, being strengths-based, being supportive of just all aspects of the youth's life when possible. And here's a brief list of some evidence-based programs that you can access that will give you a sense of what are some of those options in terms of the education piece. So those are your, you can go to any of those websites, and I'm happy to send them to you after that. So thank you, and I am going to pass it along to Mary.
Hi, my name is Mary Ott. I don't yet have anything up on the screen, so I'm sort of waiting for that to start. But what I'm going to do is actually start talking about it. The other piece of evidence-based prevention for teens and young adults are long-acting reversible contraceptives, or LARCs. I am an associate professor of pediatrics and adolescent medicine at the IU School of Medicine, and my area of expertise is teen pregnancy prevention. So I both work in clinics with teens around pregnancy prevention, and I do community-based work around teen pregnancy prevention programs. I work with the American Academy of Pediatrics to co-author their position statement on contraceptives and pregnancy prevention for teens. And Marquette, do you have, I don't have my slides in front of me, so I don't know if I'm online.
Okay, I think they're actually underneath. If you just click down at the bottom on your PowerPoint.
Uh-huh.
It just click, no, that's the one to the left of that with the, yeah,
okay.
You just.
And so you want me to put my slides on my computer? I'm sorry, I missed this. Okay, great. So, and now everybody's got me online. Good. Sorry about that snafu. So, what the first slide I have is accidental pregnancies based on contraceptive method. And what you'll see if you look at the very bottom of the slide, if young women use no method of pregnancy prevention, 85, or for teens, 90% of young women will become pregnant across a year. And what you see as you go up the slide is that there are a variety of different types of methods. The implants and the IUDs at the top as our most effective methods. And so the way you would read this slide, if you looked at the Mirena IUD, if you use the Mirena IUD across a year, only 0.2% of women would have an accidental pregnancy. The other thing to notice about this slide, in addition to the way efficacy increases as you go up on the slide, is that there are two types of efficacy. The first is typical use, which is gray, and if we look down at the ring, the patch, and the combined oral contraceptive pill, when women use these pills typically, i.e. they miss days every once in a while, they're delayed refilling their patch, or they're delayed refilling their prescription, about just under 10% of them will become pregnant across a year, which is still much, much better than no method. But when they use the methods perfectly, so that's the red, less than 1% will become pregnant across the year. So there's, for methods where you have sort of daily, monthly, or quarterly use requirements, the typical use and perfect use differ. But for our LARCs, our long-acting methods, the IUDs and the implants, the typical use and perfect use are pretty similar. So because of these data, what the recommendations are from the CDC, ACOG, and the American Academy of Pediatrics are that we counsel from most effective to least effective, because there's a lot of costs, both financial, personal, and social costs to unplanned pregnancy. So we want women to be on as effective methods as they can. So when we counsel adolescents and young adults about contraceptives, we should be encouraging them to use implants and IUDs and start from, again, from most effective down to least effective. So one of the things that comes up a lot when I'm talking about LARCs is everybody's got a story of a young woman who had an implant placed or an IUD placed, had bleeding, found it unacceptable, and had it taken out. And it's really discouraging to have that happen. However, what we see is that implants and IUDs, our LARCs, actually have high levels of a continuation rates. In fact, higher than combined oral contraceptive pills or progesterone-only pills, higher than contraceptive injections, and higher than condoms only. So like around like 75 to 85% of women continue to use the method at 1 year. This continuation is not just due to the fact that it's harder to get them removed, that you actually have to see a provider to stop using it, but it's also because they have a lot of satisfaction. So what this slide does is it breaks down satisfaction by age, and the gray are my teenagers. The purple is 20 to 25-year-olds, and the black is 26-plus-year-olds. We don't see a lot of age variation. And what we find is that like 70 to 80% of LARC users are satisfied with their LARC as compared to 40 to 50% of non-LARC users. So these would be women on contraceptive injections, combined oral contraceptive pills, patches, rings, things like that. A lot of our push for LARCs as an evidence-based prevention strategy come from two major public health initiatives. The first was the Choice Project in St. Louis, and what they did was the U.S. has very, very low rates of uptake of IUDs and implants, and the creators of the Choice Project hypothesized that this was due to upfront costs and access. So what they did was in St. Louis health clinics, they provided women with counseling about all birth control methods, starting from the most effective, which were the LARCs, to the least effective, and then provided those methods the same day at no cost. And the big circle in the middle is all women, and what we find is the light blue, like 3/4 of them chose one of the long-acting methods, with most of them choosing IUDs, either the progesterone-only IUD, either the levonorgestrel IUD or the copper IUD. But even among teenagers and young teenagers, the majority of these young women chose LARC methods. So if we look at 18 to 20-year-olds, 2/3 of them chose a LARC, with more of them choosing IUDs. And even among 14 to 17-year-olds, 2/3 of them chose LARC, with a little bit higher number choosing implants. So LARCs have high acceptability, and women are likely to choose them if we remove bad barriers from them. The other project that really forms the basis for our focus on LARCs as an evidence-based prevention strategy is work done by the Colorado Department of Public Health and Environment. Partnering with their Title X agency, they provided free IUDs and contraceptive implants to women in Colorado and did fairly intensive provider education and training. So, and what they found was between 2009 and 2013, over 30,000 women in Colorado chose LARCs, and they found during this time period that if you look on the box to the right, births and abortions among young adults 20 to 24 years of age dropped 9% and 18% respectively, but among adolescents, where the most births are unplanned and unintended, they found a 40% drop in births and abortions. And so what the Colorado experience really demonstrates is that LARCs are an evidence-based approach to preventing pregnancy and preventing and improving outcomes for young women. There's also significant financial cost savings. What Colorado found was that for every $1 invested in their LARC program, they saved nearly $6 in Medicaid costs. Again, sort of supporting this evidence basis for LARCs. So what I'm going to do now is that I'm going to shift and talk about specific LARCs, because what I found is that by helping providers understand details of LARC methods, I can help you sort of talk to your patients and and feel more comfortable counseling about LARCs. So for teens, we rely a lot on the implant, and the implant is a particularly nice method because you don't need a lot of back office staff to use it. It's something that a lot of pediatricians and internists can do easily in the office. When we released the position statement from the American Academy of Pediatrics, I got an email from a residency classmate who was practicing in rural Oregon. Both of us were 17 years out of residency, and he said that he had just completed implant training because all of the kids that he picked up as newborns when he started his practice of pediatrics were aging into adolescence and needed effective contraception. So it's something that's really, it's a method that we can provide in office-based settings that's really accessible. The current contraceptive implant on the market is called Nexplanon. Its progestin is called etonogestrel. It works by inhibiting ovulation and thickening cervical mucus. So it works very similarly to the contraceptive injection. The main barriers are that it has to be placed by a provider, so you need to access providers to get to it, and upfront costs. It is, if you think back to my very first slide, over 99.9% effective. It's user independent, which means that kids don't have to remember a pill every day. People don't have to remember to return to clinic for a shot or worry about missed visits. It lasts for up to 3 years. So if you think about placing it as for someone who's like 15 years of age, you sort of carry them through high school into the start of college. It can also has some medical benefits. So a lot of young women have problems with dysmenorrhea or have a lot of dysphoria around their menses, and it can decrease cramping and suppress ovarian cycling for young women who has a lot of menstrual dysphorias. And it really has almost no contraindications. Current breast cancer is one of them, but it's a relatively, as with other progestin-only methods, it's relatively safe. It is a minor office procedure. If all goes as expected, the insertion time takes 30 seconds and the removal time takes 3.5 minutes. There's a mandatory training by the manufacturer, and if you're interested in it, you can contact the Nexplanon manufacturer for your region. It can be placed anytime in the cycle if you're comfortable, if the young woman is not pregnant, and if you're placing it outside of the first 5 days, I'd recommend a backup method for the first week. The main concern and side effects with the contraceptive implant are menstrual changes. What I found and what other providers have found is that if you provide careful counseling about menstrual changes at the start end of your at the start before placing the method, then young women have a higher tolerance for it. They're more likely, they expect it, they know that you can have menstrual changes starting out, and not all the menstrual changes are bad. So about a quarter of the young women are amenorrheic. About a third of them have infrequent spotting, and so this is sort of the group that if they know they're going to have infrequent spotting and they can wear a panty liner, they're usually able to tolerate it without any problem. 7% have frequent bleeding and 18% have prolonged bleeding, and so these are our kids that we want to also counsel about so that they call us and come back in when they start developing these patterns of frequent or prolonged bleeding, so that we can work with them. And then the remainder had no menstrual complaints. So it's only a small portion that have, it's about a quarter that will have more concerning or more concerning menstrual complaints. For irregular bleeding, as I said before, counseling prior to placement is the most important piece. The other thing we need to do is rule out gyne issues. So I work exclusively with adolescents. We have high rates of chlamydia infection, which can cause irregular bleeding. So I'll always send a chlamydia test on young women. You can also try non-steroidals, so something like naproxen or ibuprofen for 5 to 7 days. And if that doesn't help, you can do hormonal treatment and essentially giving them estrogens for 10 to 20 days. You can use a 20 microgram combined oral contraceptive pill, or you can use an estrogen, something like Premarin. The other LARC are intrauterine devices. And so here you can see how small they are. They sort of fit in the palm of your hand. We have our paperclip for size, and then we have two levonorgestrel containing intrauterine devices and one copper, natural copper containing IUD. IUDs have the highest patient satisfaction among all methods. Contrary to common lay beliefs, there's actually a rapid return to fertility after IUD use. They're safe, they're immediately active, they provide long-term protection, are highly effective, and require really low maintenance. They're really great choices for teens and young adults who may be in school, like my junior, senior in high school who's thinking about going to college, will have protection, will have a highly effective contraception for 5 to 12 years of their life, depending on the method they choose. So there are two types of IUDs available on the market in the United States. The first is the copper T IUD. It has natural copper in it. If you look at the manufacturing instruction, manufacturer's information, it's approved for 10 years of use, but there have been large studies where they found it effective for up to 12 years. In addition to being an effective form of birth control, it is also our most effective form of emergency contraception. So if you have a young woman who's coming in for emergency contraception or also is interested in a LARC as ongoing contraception, it would be perfectly acceptable to place a copper T IUD. The other type of IUD is a levonorgestrel containing IUD. There are two sizes of it, and as you can see, it's sitting in the palm of the hand at the bottom. It sits in the uterus, and remember that your uterus is about the size of your fist. The one form has 52 micrograms of levonorgestrel in it, and Mirena and Loletta are the two brand names that it comes under. It's approved, the Mirena is approved for 5 years of use, Loletta for 3 years of use. The other is a physically smaller IUD with a smaller amount of levonorgestrel in it. Its brand name is Skyla, and it's approved for 3 years of use. With teenagers, what we found is that they can tolerate a 5-year levonorgestrel containing IUD without any problems. So that's sort of our first line because it provides the extra 2 years of birth control. Almost anyone can use an IUD. There are not a lot of absolute medical contraindications. Current pregnancy, current pelvic or uterine infection, but not past infection. So if a young woman has been treated successfully for PID in the past and currently has no infection, she can be treated. Unexplained vaginal bleeding, uterine fibroids, or another type of anomaly, or uterine or breast cancer. So it's really sort of a small list of people who can't use IUDs. IUDs are particularly appealing for adolescents because they can get it and forget it. They're safe. There's no impact on long-term fertility. We used to think that young people who were nullips, who had never been pregnancy before, had higher rates of expulsion, but more recent studies are inconsistent, and so expulsion rates in nullips in some of the studies have been identical to expulsion rates in women that have already had a pregnancy. Most young women are appropriate candidates, and one of the things we found with adolescents is follow-up and side effect monitoring are particularly important. So IUDs in general are quite underutilized in the United States, and there's a variety of patient factors and provider factors that that influence this. There's a general lack of awareness of the method and a lot of misconceptions of the method. Young women will come in for contraception, and I'll have older teens that come in and I'll talk to them about IUDs, and they'll say, well, they didn't even know that they were a candidate for this, or that they would be able to get it. There's a lot of misconceptions about side effects for IUDs. Every once in a while I'll have someone come in and say that their cousin had an IUD that left the uterus, traveled through their abdomen into their lungs, and they coughed it up. And so just sort of thinking about, like, asking people sort of what their concerns are, what they've heard about it, what other people's experiences have been, are really important. There are upfront costs to IUD, so knowing the environment that you're working in and what funds are available for women for contraception will be really important. And there's been a fair amount of negative publicity and a noticeable lack of positive marketing. And one of the things that comes up with IUDs is sort of a tipping point. So I had a colleague in Denver where they had the Colorado project going on for a number of years. And she said at the start of the project that she had very few young women choose an IUD when she gave sort of broad counseling about the different methods and recommended LARCs to young women. But as the project went on and more young women had positive experiences with the IUD, she found that she had young women starting to come in and ask for implants and IUDs instead of asking for depot and oral contraceptive pills. The other piece about IUDs and underuse are provider factors. Some providers have reimbursement concerns. Some providers have fear of litigation, and there are some myths about IUD safety in terms of infectious risks and fertility risks. And what I'd like to emphasize with this talk are the benefits of IUDs. And for IUDs, the copper IUDs and the levonorgestrel-containing IUDs have different sets of benefits. The copper IUDs work by providing an enhanced cytotoxic response, so they're essentially toxic to the sperm. Copper IUDs can prevent fertilization. They are 99.2% effective. They are marketed for up to 10 years, but actually can be used up to 12 years based on large-scale studies. They're hormone-free, so if you have a young woman who's got contraindications to hormones or has tried hormonal methods and had lots of bleeding with hormonal methods, she may want to consider a copper IUD. The other thing is I have a group of young women that just like to have periods every month, and they choose a copper IUD because they'll have a period every month with a copper IUD. And finally, as I mentioned before, it can function as emergency contraception. The main side effects of copper IUDs are increased cramping and bleeding. So it's not a method you would want to use for someone who already has dysmenorrhea and heavy periods. In fact, you would consider a levonorgestrel IUD in those cases. But for someone who has average periods, we can just monitor for cramping and bleeding. There is a small proportion that will have an expulsion, and even in a much tinier number that will have perforation. And perforation is due in part to, related in part to skills of the operator, which means that I would recommend as you do this, making sure that you get training, and then that you do enough as part of your practice to maintain your skills. Contraindications are rare. Essentially, there can be anatomic contraindications, things like fibroids, or among young women, they may have congenital anatomic differences, or young woman with an active infection. So levonorgestrel-containing IUDs have slightly different benefits. So in addition to the mechanism of the IUD, levonorgestrel additionally thickens cervical mucus. It's similarly highly effective. It lasts for 3 to 5 years depending on the particular IUD that you choose to place. It decreases cramping and can be used as a treatment for endometriosis. It also markedly decreases blood loss and often induces amenorrhea. So for instance, women who have used Mirena have 90% less blood loss, and it's been used in older women as a treatment for menorrhagia, and can be a really nice method for menstrual suppression among younger women and even young women with disabilities. For levonorgestrel, the bleeding and cramping is usually limited to the first week to the first couple months. After that, you have similar side effects as with other levonorgestrel-containing, other progestin-only methods, so like the contraceptive implant and the contraceptive injection, where a proportion of young women will have irregular bleeding. There is some concern that expulsions are higher in nulliparous women, but again, the data are not all consistent, and the contraindications are anatomic or infectious. Inserting an IUD requires a bimanual exam, a speculum exam, and then you make sure you clean the cervix. Many people will use a tenaculum. You sound the uterus and place the IUD. So it's basically an office-based procedure. There's no evidence for cervical dilators. Young women can be pre-treated with nonsteroidals, and this can sometimes help with the cramping. And they can be inserted at any time if you're reasonably certain that someone is not pregnant. If they're more than 7 days from their menses at insertion, they should use a backup method for 7 days, like a condom. And STD testing should be done per the guidelines, or at the time of insertion. And we recommend not inserting for someone who has a known infection or a purulent cervicitis. But if a young woman is completely asymptomatic, you can send the STD testing at the time of insertion and treat with the IUD in place if needed. The last question that comes up with IUDs and implants is how to be reasonably certain someone isn't pregnant. And some of the things that we think about is the amount of time since the start of menses. So if it's less than 7 days since the start of menses, you can be pretty certain that they're not pregnant. If they haven't had sex since their last method, you can be reasonably certain they're not pregnant. If they've correctly and consistently used contraception since their last menses, so if you have a young women, we have a lot of young women who are on contraceptive injections and then transition to an IUD or an implant, and as long as they're within the 15 weeks for their contraceptive injection, we can be reasonably certain they're not pregnant, or if they're within 4 weeks postpartum. If they fall in this area, a urine pregnancy test isn't necessary, although we all tend to do them. Because of these data and because of the accessibility of LARCs, where they can really be office-based, minor office-based procedures, ACOG and the American Academy of Pediatrics have both shifted to recommending LARCs as first-line agents. So ACOG says when choosing contraceptive methods, adolescents should be encouraged to consider LARC methods, and the AAP says that LARC methods should be considered first-line contraceptive choices for adolescents. So there's a lot of policy support for their use in teenagers and young adults. And then follow-up. A lot of adults will not get a routine scheduled follow-up visit. The provider will suggest that they check their strings for their IUDs. With teens, we tend to do routine follow-up, in part to troubleshoot and in part to reassure. We want to be available for questions and encourage them to call or come in for concerns. It's much easier to deal with many of these concerns in a prospective way. So if a young woman has a week or two of bleeding, it's better to get her in and get her seen and address the side effect rather than wait until she comes in a month or two later asking to have the method removed. And there are a lot of benefits of routine follow-up. So we can assess their satisfaction, we can check for strings with IUDs and help them check. We can discuss plans or if they, discuss their plans for continued contraception, or if they want a removal, schedule a removal. And then management of side effects. And I talked a little bit about this with implants, but bleeding irregularities are the biggest side effect, and counseling before placement is the most effective method. Again, considering a gynecologic issue. So in particular for young women, I would be thinking about chlamydia as an STD. Is there an expulsion or a partial expulsion? Is there a new problem? For progestin-containing IUDs, I tend to counsel initially because the bleeding often decreases with time. We can also use nonsteroidals for 5 to 7 days. If a young woman who has an implant or has an IUD in and comes in with PID, the recommendation is to treat the PID and monitor her for 48 hours. And if she gets better in 48 hours, then we can finish PID treatment with the IUD in, and not consider removal until we hit the 48-hour mark. If a young woman comes in with concerns about pregnancy, the first step is, particularly with an IUD, is to evaluate for ectopic pregnancy. Removal of the IUD can improve outcomes if it's able to be done. If the IUD is in place, it does present a risk for spontaneous abortion, preterm labor, and chorioamnionitis. So it would be important to refer them to high-risk OB and talk to your high-risk OB colleagues. And one of the things we really don't know, because there's not a lot of post-marketing experience, is what happens if a levonorgestrel IUD is, we don't know if this is associated with fetal anomalies or not. Expulsion, you can always replace it at the time of removal, or you can switch to another method. Young women who have had one expulsion are oftentimes at an increased risk of re-expulsion. And the last thing I want to end on are resources for patients. This is done by a national organization called the National Campaign to Prevent Teen and Unplanned Pregnancy. And what they did was they got medical providers and young people together and designed a birth control support website. The young people chose the method, and they chose bedsider.org. And the thinking was that they wanted to have a doctor, if there was the same as having a doctor or a medical provider at their bedside. Bedsider is a great site for contraceptive information, because the information is both medically accurate and given in a form that the young people can understand. When you go to their Birth Control Explorer, you get this picture of all the different types of methods, and you have this little green box that says Bedsider recommends, and I'll say, and I recommend also the implant and the IUD. The other resource for young people is done by the same organization. My other favorite resource, so there's a number of resources out there, is stayteen.org, and this is geared towards younger teens. It is done by, again, the same organization, the National Campaign to Prevent Teen and Unplanned Pregnancy. Stayteen has information that's a little bit more simplified, a little less edgy, and has some really great information on healthy relationships and deciding to wait. And they also have a Birth Control Explorer that looks an awful lot like the Bedsider Birth Control website, although in line drawings. And what I have here on the screen are the Birth Control Explorer, where they show the implant and the IUD. Again, like appropriate, effective methods for young people. So I think on that end, on that note, I'm gonna end it, and we can take questions. And I think the questions are going to go to Abby and Marquette.
Okay, I don't see any questions, so we'll wait just a couple minutes here and make sure that people have time to think and ask any questions they may have.
Okay. Okay, I do. It looks like there's a question. Is there a printable summary of the information provided today?
We can. I'll talk to Mary about how we can share a summary of this information.
And then the other thing is, depending on the information that the person is interested in, there are some easily accessible evidence-based sources. So Bedsider has a provider information website that you're directed to. If you go to bedsider.org, there'll be a place for from providers. A lot of the information on IUDs and implants that I have came from a publication called Contraceptive Technology, which is really very much the contraceptive Bible. And that's again something that should be accessible to many of the people. And so, if there are sort of the other thing in addition to Abby's and my slides, I think what we can do is point people towards sort of existing published resources.
We do have a link of resources and programs that we can send out to you that my organization has in terms of programmatic and evidence-based programs and protocols. So we'll send that to you.
Okay, Abby, are you seeing the other questions that are coming up?
No.
Okay, I do have another one. What information do you provide pertaining to breastfeeding and milk production with the implant?
I'm going to unmute myself I was muted and I apologize for the delayed thing. I have a little bit less experience with breastfeeding because what we do with our teen OB patients is I don't provide OB care as a pediatrician. So they are still with the OBs when they come to me, but that's information that I can get to you. Because I think a lot of these methods, like implants and some of the other methods, our OB colleagues are using them fairly early post breastfeeding. I mean, post delivery.
Okay, and we have another question addressing the cost issue. Are any LARCs available in generic form? Are most LARCs covered by health plans?
And can you repeat the first part of the question?
Sure. It's addressing the cost issue. Are any available in generic form? And then
so most so right now there are not like specific generic forms of either IUDs or implants. However, most private insurance plans will cover costs of LARCs. Most state Medicaids will cover costs of LARC. So, for instance, Indiana Medicaid covers the cost of the LARC, and then Title X can provide LARCs at very low cost. So, so it would be something that the individual should first check with their insurance plan and make sure that it's covered, the method that they want is covered, and then they can look at some of these other options like Title X as possible alternatives if their insurer doesn't cover it.
And Title X, I'll just add Title X care providers in Indiana specifically. You can find providers through the Indiana Family Health Council. You can just Google that and find their website, and then you can find those resources.
Okay, I'm not seeing any more questions. We'll wait just a minute and see if anyone sends in any more questions, and we'll wrap it up.
I don't have any other in my view either, Marquette.
Okay. All right. Well, thank you so much, Abby and Mary. We really appreciate the webinar today. Great information. Such important work both of you are doing. So Thank you much. And if anybody would like to get a hold of Abby or Mary, please contact Indiana Perinatal through our website, or you can email ipn@indianaperinatal.org. And with that, we'll go ahead and close the webinar. Thank you again.